APL was once considered the most dangerous of the subtypes of AML, and I think we can say that this kind of statement has undergone a substantial change in the last 5 years. The reason for this is that we made some progress with regards to incorporation arsenic trioxide as the most active single-agent treatment into frontline treatment of patients with non-high-risk APL. The data of the Italian-German randomized study using conventional idarubicin and ATRA-based chemotherapy versus the chemo-free ATRA-ATO regimen has shown not only a substantial benefit with regards to disease control, but also a survival benefit. And at the end of the study, and also the study data led to the registration of arsenic trioxide in the first-line treatment of patients with APL. So now 2/3 of newly diagnosed APL patients can receive treatment which is completely free of chemotherapy. So it's ATO, arsenic trioxide, and ATRA based. And I think this is a great success in the treatment of APL patients, and the majority of them can now be cured with this kind of regimen. So what are the challenges we are still facing in APL? First of all, it's the so-called early death rate. So a couple of patients, according to registries, there might be up to 20% of the patients, they do not come to the point where they get the effective treatment of APL due to delay of diagnostic approaches, due to severe bleeding complications at the early phase of the disease. So I think we need to foster strategies to improve awareness of this situation and include patients more into studies, but also improve the kinetics of diagnostic approaches and treatment access to these patients. The second most important challenge is the care of patients with so-called high-risk APL. These patients are roughly 1/3 of APL patients. They have a proliferative APL, so they have leukocytes above 10,000 at diagnosis. And those patients are still undergoing conventional chemotherapy in combination with ATRA as the first-line treatment. At the moment, there is an ongoing European study, the so-called Apollo trial, which actually aims at comparing prospectively the conventional backbone of chemotherapy plus ATRA with an arsenic trioxide-based treatment regimen in a 1-to-1 randomization. The study has been opened now in more than 50 centers in Europe, in Spain, in France, Germany, Italy, but also in Netherlands. And we hope that maybe in 2 years from now we will have some data supporting the idea that arsenic trioxide might also play an important role in the treatment of these patients.